Hi everyone. So I'm Katja. I'm employed by Novo Nordisk, but I'm here also on behalf of the IKEA for CVD project. So first, just let me tell you what is IKEA for CVD. IKEA for CVD is international public-private research initiative that aims to bring precision medicine closer to cardiovascular care. It says IKEA for CVD, and CVD stands for cardiovascular disease. It's a very large project, as you see, with many academic and industry partners. And the main idea is quite simple. Basically, we have a lot of clinical rich data and how we can use it to move beyond one-size-fits-all guidelines towards more individualized decision support. Okay, so today we as humanity have a lot of clinical data, more than ever. So if you think about electronic health records, for example, NHS, every patient visit, every lab biomarker, every diagnosis, every prescription, everything is being recorded, everything digitalized, and you can access. On top of that, there are pharmacy claims, there are registries, there are trials, there are biomarker databases. So there is a lot of data. So in theory, we should have enough data to deduct how treatment effects will vary across individuals. Unfortunately, or not unfortunately, basically clinical guidelines are still based on one-size-fits-all approach. So these clinical decisions are based on average treatment effects. So basically what works for population becomes a recommendation for individual. In the best case scenario, we stratify into subgroups, but it's still very far from true personalization. And in an ideal world, actually, what would we like to know is, given this current patient profile, their comorbidities, their biomarkers, what's the most optimal treatment for this specific patient. It comes with a lot of opportunities, so you can do more tailored drug selection, so specific drug type, or you can also go with tailored dose. That's something that we were focusing on. Basically, if you know the drug, but you need to select the most optimal dose for this patient. And then you can also avoid with these trial and error titration strategies. You might have experienced that as well. If you go to your doctor, they will prescribe you average treatment, and then they will like, oh, let's try this other one and see how you react, and then try another one. So basically, we move away from reactive care more towards data-driven, individualized support. Theoretically, we also have the methods, and this was, I think, presented by many colleagues here. So there are methods to estimate individual treatment effects, heterogeneous treatment effects, such as causal forests, meta-learners, double machine learning. So there are a lot of methods, and the toolbox is ever growing. So the question is also why, if we have the data, we have the methods, why we still treat patients with average treatment effects, and why there is no precision medicine in our actual clinical practice. And that's because there are challenges. So one of the large challenges, as I see, data is very fragmented. So data is scattered across hospitals, registries, countries, and it's hard to bring it together. And what we are actually doing in IKEA for CVD, we are making a federated database of cardiovascular cohorts, but this is still a tiny fraction of clinical landscape. And to actually make a precision medicine a reality, it has to be tackled on a huge national or international level, trying to bring all this data together. But besides bringing the data, there are also method challenges. So first, there is also, if we look about observational data, comparator availability can be a challenge. So when you talk about treatment effect, you want to think treatment effect compared to what? To other drug, to no treatment, and then groups also have to be comparable of the patients. So if one group is given one drug and the same disease group is given another drug, there might be a reason. So some people can be more severe, so there is always confounding. Of course, we're trying to use causal inference methods, but if there is a positivity violations and groups are not comparable, nothing can fix that. Treatments are also very complex in real data, so patients are on multiple drugs, patients switch drugs, so you really need to think about your design. Do you censor patients when they switch to another drug? Do you use intention to treat approach? So there are all these questions. There can be residual confounding as well, because obviously with causal inference you adjust for confounders you see, but symptoms and a lot of other things may be not recorded in your data, but prescriptions were made based on the symptoms as well. Another thing that we encountered very complicated is validation of individual treatment effects. So average treatment effects, if it's a known drug, you might know that this drug works from clinical trials or common knowledge. But individual treatment effects is a counterfactual quality, and you don't really know the ground truth. You can try to validate things with synthetic data or see that patients that have larger treatment effect are dying less or have less hospitalization, but it's still very, very proxy and not so trustworthy. And then uncertainty is also very large. I think the previous speaker also talked about that. So you can have very large confidence intervals for average treatment effects, but when you go to the individual level, they can span both benefit and not benefit, and then basically you need to decide how to make a clinically meaningful decision, what is the threshold on your confidence interval. So overall, I wanted to say that it's exciting. We have a lot of data, we have a lot of methods, but there's still a huge gap making this actionable and trustworthy and doing individualized clinical decision support based on that. And thank you all. And also, if you're interested in IKEA for CVD, very welcome to reach out. Thank you.